Hello, this is Dr. Stephen Morris. I'm continuing with the lecture series for Anatomy and Physiology 1. The topic today is on acid-base balance. This is an important aspect of human anatomy. We've already talked about the key electrolytes, anions, cations that are involved in the human body. We'll also take that a step further now and show how those anions, cations can affect the acid and the base balance inside the human system as well. Now, we've already alluded to in previous lectures that homeostasis is a steady state or a balance inside the human system. Homeostasis can refer not only to the temperature regulation system, but also pH balance as well. The human system is based upon homeostasis, ideal conditions for human and cell tissues to be able to survive, and ideal conditions include temperature, nutrition, and pH. The normal pH, and pH refers to as the hydrogen ion concentration, which I'll talk about in just a little bit, but the normal pH range lies between 7.35 and 7.45. If there had to be a neutral point that would be picked, it would be serum level of pH of about 7.4. But a normal range for the human body, 7.35 to 7.45. Now in extremes, and as you can see by the illustration, in extremes a pH of 6.8 results ultimately in death, and a pH greater than 7.8 ultimately leads to death as well. So it's a very narrow range the human body has to exist in. Normal values of pH can vary depending on the lab. Here the reference scale is 7.36 to 7.44, again depending on the reference lab that you're in. This is a range. It's not an exact number that a given individual, but it needs to be within this range for human tissue to be able to survive. Acidemia occurs when a pH is lower than 7.35, or in this case 7.36 because of the reference lab. Alkalosis occurs when a pH is greater than 7.44. In the previous slide we say 7.45, again depending on the reference range or the reference lab that you use. Other important values when we talk about pH balance. There is a concentration of O2 and a concentration of CO2 that exists in the human body, particularly in the cells and in the intravascular space. The concentration of CO2 needs to stay within a range of 35 to 45 millimeters of mercury. The range of the oxygen concentration needs to stay between a range of 70 and 100 millimeters. In acid-base disorders, what happens is we see an alteration in this pH balance. One of the things we do to analyze what may be going on in the system is to analyze the electrolytes. We've already had a discussion about electrolyte balance when it refers to sodium, potassium, chloride, calcium, which are some of the key electrolytes. Today we will address particularly the hydrogen ion and its concentration and its effect. So one of the things to help analyze what's going on in pH balance in the system is to analyze the electrolytes. A formula will help us to determine what's referred to as an anion gap. Again, anion referring to the negatively charged electrolytes that are in the system, and this will help in the determination of the pH. Some electrolytes to consider: potassium, chloride, which we talked about in an earlier lecture, and then bicarbonate, which we'll talk about in more detail today. One way to analyze these electrolytes or to analyze the concentration of oxygen and carbon dioxide is to perform arterial blood gases, or drawing blood from an artery, such as the radial artery in the wrist, the femoral artery. These arteries have higher concentrations of O2 versus CO2. I can also analyze the electrolytes that are in the intravascular space as well from this blood sample. This should be obtained concurrently. In other words, performing the blood gases without also analyzing the electrolytes may not lead to a correct calculation in some of the pH abnormalities that you will have to be faced with. Now, bicarbonate, increased level in metabolic acidosis. So pH levels that are elevated, in other words, greater than 7.45, typically have high levels of bicarbonate. The increased level is compensated by respiratory acidosis. In other words, the lung center, will attempt to compensate elevated levels of sodium bicarb by increasing CO2 levels to offset this metabolic alkalosis. You also may see decreased levels in metabolic acidosis, and you would also see decreased levels in compensated respiratory alkalosis. And potassium levels, serum potassium levels are typically increased in patients who suffer from acidemia or low pH levels. You also see decreased potassium levels in alkalemia, or patients who have pHs that are high or greater than 7.45. You may also see a change in the pH of 0.1, which will lead to a change in the potassium level of 0.6. And remember, potassium levels are typically measured 3.6 to about 4.2 for a normal range. Now, serum chloride matches proportionally with sodium, as we've talked about in earlier lectures. If you increase or decrease as a result of patients' hydration and dehydration. High chloride levels typically are reflective of acidosis, particularly metabolic acidosis, which do not have a respiratory component, and then you also may consider it in respiratory alkalosis. Low chloride levels are considered in metabolic alkalosis, and you could also consider respiratory acidosis as well. Now, in these pH balance extremes, there has to be a degree of compensation. And you do this in order to distinguish whether it's a simple acid-base disorder and compensation is taking place, or whether this is a mixed acid-base disorder simultaneously with the presence of two or more abnormalities. Simple acid-base disorders include metabolic acidosis and metabolic alkalosis, or respiratory acidosis and respiratory alkalosis. There are formulas that are used to calculate the degree of compensation and whether or not it's adequate. Won't go into the details about the formulas that are used, that you won't be responsible for that. But basically, I do want you to appreciate the number of organ systems that are involved in maintaining adequate pH balance. This is an interplay with not only the organ systems, but also the electrolytes, which are a part of this system. Cell metabolism, and again, we've talked about the intracellular machinery and organelles that carries on metabolisms inside the cell. But that metabolism inside the cell generates acid and other products. The production of acid is typically in the form of hydrogen ions. Also, blood, there's carbon dioxide and water. It combines to form H2CO3. And then there's also hydrogen ions that will bind to bicarbonate as a buffer. The kidneys are also responsible in this process as well. See, the kidneys also will help to retain and excrete hydrogen ions in sodium bicarbonate. We also see the buffer actions of particular substances in the system. Sodium bicarbonate can help to neutralize some of the acids that are being generated. And subsequently, carbon dioxide, which is produced as a waste product from cells, can combine with water and form H2CO3. And then more acid in the blood and less bicarbonate will lead to a buffer. We see the cardiovascular system is certainly affected by these concentrations. Subsequently, it can also affect the lungs. In acidotic conditions, the lung tries to generate buffers to help counteract that, and we'll see increase in respiratory patterns as well. Now, there are a number of formulas that are created to help demonstrate compensation, particularly in forms of acidosis. You will not be responsible for these compensatory formulas. It is important to just recognize that in metabolic acidosis, there's a compensation that will occur in the body. Usually if the PCO2 is greater than what you calculate in the formula, then both metabolic and respiratory acidosis is present. If actual PCO2 is less than what's calculated, then both metabolic acidosis and respiratory alkalosis exist. In an acute setting, increase in PCO2 by 10 will decrease the pH by 0.8. An increase in the bicarbonate level by 1 milliequivalent as well. The usual upper limits of compensation for bicarb is 30 milliequivalents. Chronic increase in PCO2 of 10 will decrease the pH by 0.3 and will increase the bicarb by 3.5 milliequivalents per liter, the usual upper limits of compensation. An increase in bicarb by 1 will increase the pH by 0.15 and increase the PCO2 by 0.7. Some limitations: the compensatory response that increases the partial CO2 or PCO2 level is usually limited by a maximum PCO2 of 55. There is an impaired compensatory response in patients with chronic obstructive pulmonary disease, heart failure, and hepatic coma. Acute decreases in PCO2 by 10 will increase the pH by 0.08 and decrease the bicarbonate level by 2.5. Chronic decreases in PCO2 by 10 will increase the pH by 0.3 and decrease the bicarbonate level by 5. The golden rule in acid-base balance: changes in PCO2 either up or down, or 10 milliliters of mercury, will increase or decrease the pH by 0.8 units. Key teaching point: as a rule, if PCO2 increases, the pH will fall. Also, pH of 0.15 is a result of a base change of 10 milliequivalents per liter. Teaching point: subtle changes in the pH result in change in the base change or bicarbonate level. The total bicarbonate deficit is equal to the base deficit, milliliters over liters, times the patient's weight divided by 4. This is just one of the formulas that can be used to help determine the bicarbonate level in the human body. The use of 100% correction of acute condition: acute cardiopulmonary arrest, cardiopulmonary resuscitation, acute respiratory failure; use of 50% correction for subacute or chronic conditions. A term referred to as anion gap refers to the unmeasured anions in the plasma of negatively charged ions on the plasma protein and negative charges contributed by organic and inorganic anions, which are normally present in the plasma but not routinely measured. Variations among labs and variations in chloride level may occur. There are two classes of anion gaps: normal anion gap acidosis due to hyperchloremia, elevations in the anion gap acidosis, AG acidosis. Most significant cause of high anion gap acidosis are metabolic acidoses, in which bicarbonate has been titrated by organic acids, for example, lactic acid and ketoacidosis. For each increase in 1 milliequivalent of the anion gap, there should be an equal fall in the serum bicarbonate. In normal anion metabolic acidosis, every increase in 1 milliequivalent of chloride in anion has an associated decrease of 1 milliequivalent in bicarbonate. Discrepancies in these changes may indicate mixed acid-base disturbances. There are organic acidosis when anion gap is at least 25 to 30 milliliters per deciliter of an organic acidosis. Most always present regardless of bicarb level is reduced. There are some etiologies of acid-base disturbances. These include lactic acidosis in the form of anaerobic metabolism, which produces increased levels of lactic acid. Aerobic types of lactic acid metabolism, similarly still, lactic acid levels will accumulate. And then in ketoacidosis, again, diabetic is the most common patient that you see that in, but you can also see it in ethanol intoxication and forms of starvation. Etiology of acid bases, especially metabolic acidosis, uremia, chronic renal failure, ingestion of toxins, peroaldehydes, methanol, salicylates, ethylene glycol or antifreeze, and then high-fat diet. In the differential diagnosis, you have to consider diabetic ketoacidosis, alcoholic ketoacidosis, peroaldehyde poisoning, the history of ingestion, positive urine test for acetaldehyde, and then a positive toxicology screen. For anion gap acidosis, positive for urine ketones or ketosuria, starvation, high-fat diet should be considered. Renal failure, elevated BUN, which is blood urea nitrogen that's measured in the bloodstream, or creatinine levels. Lactic acidosis, elevated lactic acid levels, methanol poisoning, visual, which can lead to elevated osmotic gap, and visual impairment. Positive toxicology screen is usually seen. In ethanol glycol poisoning, elevated osmotal gaps will occur. Calcium oxalate crystals will form in the urine. Positive toxicology screen. You also can see in salicylate poisoning normal osmolar gap, history of ingestion, positive toxicology screen, purple color in the urine, 1 cc of a 10% ferric chloride is added to 3 cc's of urine. Also in renal tubular acidosis includes aldosterone deficiencies. We talked about aldosterone before. Interstitial loss of bicarbonate, diarrhea, pancreatic fistula, carbonic anhydrase inhibitors, acetazolamide, some medication that can be used, and then dilutional acidosis, rapid infusion of bicarb-free and isotonic fluid. In hypokalemic acidosis, you'll see the ingestion of exogenous acid, ammonium chloride, methionine, cysteine, ileostomy. Drainage bag can cause this form of acidosis. Uridosigmoidoscopy, and then also drugs such as amiloride, triamterene, spironolactone, and beta blockers. The hyperchloremic metabolic acidosis measurement of urinary anion gap and urinary pH is useful in the determination of differential diagnosis of hyperchloremia and metabolic acidosis. Negative anion gap suggests GI loss in the bicarb. Positive anion gap suggests altered distal urinary acidification. Low urinary pH and elevated plasma potassium in patients with positive urinary anion gap suggests selective aldosterone deficiency. Urinary pH of 5.5 and elevated plasma potassium suggests hyperkalemic distal renal tubular acidosis. Urinary pH of 5.5 and normal or decreased plasma potassium indicate classic renal tubular acidosis. So what is the therapy? Well, you want to correct the underlying cause of the acidosis. If it's diabetic ketoacidosis, you need to treat that. If it's diarrhea, you need to treat that as well, uremia. Sodium bicarbonate is given only, and again, underline only, life-threatening cases. And even in life-threatening cases, we're very reluctant to give sodium bicarbonate. It uses its use still remains controversial, especially in cardiopulmonary arrest. The problem is the process called overshoot alkalosis, where overaggressive use of sodium bicarbonate, bicarb levels should only be corrected to about 1/2 of the bicarb deficit in a 12-hour period. But the administration of boluses of sodium bicarbonate typically will overcorrect or overshoot the point. Hypernatremia and fluid overload following sodium bicarbonate therapy are of particular concern, especially in patients with renal failure and congestive heart failure. Now, respiratory acidosis can occur in patients with significant pulmonary diseases, chronic obstructive pulmonary disease, pneumonias that are severe, pulmonary edema, and interstitial fibrosis. Respiratory acidosis, airway obstruction, foreign body, severe bronchospasms or laryngeal spasms. Thoracic cage disorder, pneumothorax, flail chest, kyphoscoliosis all can lead to respiratory acidosis. Defects in the muscles of respiration can also lead to acidosis, include myasthenia gravis, hypokalemia, and muscular dystrophy. Respiratory acidosis also defects in the peripheral nervous system, amyotrophic lateral sclerosis, poliomyelitis, Guillain-Barré syndrome, botulism, tetanus, organophosphate poisoning, spinal cord treatment, all are important. Depression of the respiratory center can also cause respiratory acidosis. You can see that with anesthesia, narcotics, sedatives, vertebral artery embolism, thrombosis, increased intracranial pressure. For respiratory acidosis, failure of mechanical ventilator, ineffective bag mask ventilation, chloride responsive, urine chloride levels less than 15 milliequivalents per liter, chloride resistance, urinary chloride greater than 15 milliliters per liter. Chloride responsive to alkalosis, vomiting, NG suction, diuretics, post-hypercapnic alkalosis, stool losses, laxative abuse, cystic fibrosis, massive blood transfusions, or exogenous alkali administration. Metabolic alkalosis, chloride-resistant alkalosis, hyperadrenocorticoid states such as Cushing's syndrome, primary hyperaldosteronemia, secondary mineralocorticoids, use of licorice and chewing tobacco, hypomagnesemia, low magnesium levels, hypokalemia, or Bartter syndrome. Chloride-responsive forms are treated with saline and administered, and correction of accompanied hypokalemia. Chloride-resistant forms require correction of underlying cause and the associated potassium depletion. In respiratory alkalosis, hypoxemia, drugs, CNS disorders, psychogenic hyperventilation, hepatic encephalopathy, gram-negative sepsis, hyponatremia, sudden recovery from metabolic acidosis, and assisted ventilation. In hypoxemia, you can see pneumonia, pulmonary embolisms, atelectasis, and high-altitude living all playing a role. In respiratory alkalosis, salicylates, xanthines, progesterones, epinephrine, and thyroxine, and nicotine are used. CNS disorders associated with respiratory alkalosis include tumors, strokes, trauma, and infection. Psychogenic hyperventilation from anxiety or hysteria can also falsely elevate the serum pH. Then therapy for respiratory alkalosis. The therapy for respiratory alkalosis is aimed at the underlying cause. For example, symptomatic patients with psychogenic hyperventilation often require some form of rebreathing apparatus, either a paper bag or a 5% CO2. That just gives you a brief overview of pH balance. This ends the lecture series on pH balance. Thank you.